I really want to thank our current participants on this panel. It really is an honor to sit here with all of you.
Absolutely. Thank you. These are crucial conversations. And I know we were waiting on bated breath to hear what many different perspectives were for perspectives on opioids. So I'm just going to invite everyone to put their video on. For now, we can have our mics off. So welcome, everyone. We are running a little bit later, but this is consequential to the fact that this is so important. And whoever's joining us, thank you so much. I was hoping we could approach this from a very broad perspective to have some questions and then maybe some rapid fire questions, but we're going to have a conversation. So I'm just going to make some general comments right now, because what I heard is that we're balancing knowledge. We're balancing what are opioids? How can we have those conversations with each other? We have policies, we have guidelines, we have real world. We also have real people. And what I heard clearly from Guy, and again, lots of accolades about sharing your powerful story, by the way, Guy. So just want to pass that along. And thank you too, Claudine, for that. But we need to bring the human connection back, and that can be often overlooked. So what I'd like to pose to everyone is just a little bit of perspective. So Rob, you mentioned primary care networks. I work at a primary care network. I'm a clinical pharmacist. So the key thing is that when we look at primary care and we look at physicians, allied healthcare professionals, our level of knowledge, our skill set is different. How can we start these conversations, period, about opioids? Not going one way, not going the other way, but how can we just start these conversations? And I'm going to start with either Guy or Claudine. I would love to hear what would be helpful and what would have been helpful. That hindsight is 2020, and I'm sorry for the pun. But in any case, I'd like to start us off with that, if we could. So,
they're so kind. Nobody wants
ladies first. Aw.
Thanks, Guy. I prefer an approach that is direct and tells a story and gives me as much information as I can so I have options and choice. I am capable of making decisions. I want to make decisions. I want to be an effective person in my own care, and I need help. I need a team. I need a supportive therapeutic team. My prescribing physician is very important to me. That individual needs to be able to tell me all of my options, needs to tell me why they can work, what can be the concerns related to them. I have to be able to make those decisions for myself and for the betterment of my family. I would also say, and you heard me show Mohamed as my special friend pharmacist, he does the same thing, and he's validating and he's supportive, as are my physical therapists, my massage therapists, my therapists in general, all of it. I've chosen, and I work with a team that cares about supporting me and can help me understand my options. And so that's where I would introduce the topic of choice.
Yeah, I'm an option guy myself. I like that part of it. And I can remember many moments where people shared a little bit about them, because, when you're coming to a clinic, you're very nervous, you're anxious, you're struggling, and you're trying to get support. And I just remember somebody asking me, well, what's not working? And then I explained what wasn't working. And then they asked me, what do you think would work? And that really helped a lot. And we actually, maybe I said this would work for me a little bit, on the higher level. And we came to a middle ground together. But it meant that I was part of the conversation. It wasn't him just saying, well, no, I can't give you that. We got to a place together. And a really powerful moment was I was just a mess, and somebody just, shared, do you feel black? And it was a doctor, but I looked at the doctor, was like, well, what would you know about being black? And he talked about his own depression. And I tell you, that changed everything for me, because I even said, you're a doctor and you have depression. It didn't compute that other people are going through the same thing, right? You think people are well put together, you've got a career, you make 250, whatever you make. And that really hit home to me, because that developed our relationship moving forward. And it turned out to be, probably the reason why I have a leg today. And eventually why I have the recovery that I have today. I mean, it was an amazing thing. And that's why I've always gone back to this thing with human connection. And it's just, if addiction is that isolation piece, then why aren't we connecting? And why aren't we connecting on a level where it meets people where they need to be and where they need to hear? So it was just a powerful, I think the option thing is the most important as well. So thank you.
Oh, absolutely. It sounds like, leaning in and just remembering that we all are human. I remember Julie from yesterday's presentation spoke about that we come to work with our heart. I can relate to that when I practice, and we all need to, relate to one another. So I'm curious about, Dr. Kertesz or Launette, Dr. Rieb, if you have any other perspectives, just to start that conversation about opioids.
I'll comment on a couple aspects of this. As I was listening to Guy and Claudine, I realized that they were describing an ideal situation for care. And I was asking myself, what is it about people in the health professions or about the way health professional work is constructed that gets in the way of that? And a couple things that really resonate for me are that the way we select people to be doctors is based on compliance, adherence, and pleasing figures of authority. This is literally what you have to be and do in order to get into most medical schools and to get promoted along the way. So that attitudinal background means that we sometimes expect that of the people we take care of. And it also means that we're often not thinking very creatively and openly when contending with complex human problems. It hinders matters more that the training on pain, on rehabilitation, and on addiction has been poor in at least US-based medical schools. And there's not been a major rush to fix that. There's a little bit of correction because of a massive number of deaths, but it would have seemed to me that we would have done a lot more by now. And then I think that if you think about those of us who become particularly doctors, maybe it's a little less so with nurses, adherent, compliant, hierarchical, when we then become the leaders or people who structure our healthcare systems, we set up rules, metrics, which make things seem routine, regular, and predictable and controllable. And then we often either intentionally or unintentionally governed by fear. This means that when a frontline clinician is worried that they cannot provide good care or that they see a patient harmed, either by blowing the prescription pad up and prescribing way too much or by stopping everybody, they are actually afraid to report that they're seeing a problem in care. And when they do report it, they're told, now, we have it under control. I'm sorry you're having a little difficulty there, wherever you are, in Alberta or California or Alabama. So I think there's some cultural barriers within medicine and healthcare that contaminate good work.
Thank you. Again, I'm going to offer it out to anyone else who'd like to add, because I think this is the core. The foundation is having those conversations. And sometimes we forget about that. We have to start from the beginning. So if anyone else would like to add, please go for it.
I think sometimes it comes down to understanding what the research shows us, but having an ability to personalize with the individual in front of you. Because an individual will have risk and protective factors that are not outlined in any study. So I try to elicit from the person who's with me what their goals are, what their thoughts are, what they know about what they're taking, what their fears are, what their family's concerns are, and see what their strengths are. And how can we pitch to their strengths, help to buffer from the potential harms, be they using or wanting to come off or whatever that is. So I'll give you an example of a way to kind of integrate that biopsychosocial with something practical. So for example, let's say you have a patient who has tried coming lower because they had a desire to come down on high dose opioids, and they've been a long-term person and they're highly neuroadaptive and they haven't been successful. Well, sometimes, and you've tried all the tricks in the trade and things. So sometimes it's just to pause and say, well, let's really look at what your risks are. Let's see what your risks would be if you come off, your risks if you stay on. Do you have sleep apnea? So let's do a level 3 sleep study. Well, you have no sleep apnea at night. Well, despite the fact that you're on a fairly high dose, you'd probably be at lower risk of unintentional overdose at night, as long as you don't binge drink or anything. So that kind of practical measure, and are you driving? Are you, just to look at all the risks in their own life, and maybe they're not at such risk compared to what the literature might say. So there's ways to go down, and I keep kind of in my head a checklist of about 15 things to kind of go over with them to try to assess their personal risk and protective factors to see where they might and see what their desire is around that. Also, a lot of patients don't know of potential harms, and they don't know of some of the potential harms of coming off. So both of those need to have, I believe, totally an informed consent. So both Claudine and Guy really outlined that engagement, wanting to be walking beside the person on their journey, being with them, and really helping to put empower them with the skills and knowledge that I have so that they can make good decisions for their own life.
Thanks very much. And I know this is real life. So thanks so much for joining and having someone new come join us. Thanks, Guy.
That was awesome. I don't know how I've kept mine out. So look, I'd like to quickly comment on that. And I think we've heard from people, the relationship is the most important thing. I'm a psychiatrist. I got a lot of training in understanding and treating mental health. And a lot of that is based on behaviorism and cognitive behavioral type therapies. But I couldn't do any of that without a relationship. It is useless without such. And when we step back at the systemic level, and Stefan is really good at stepping back at this, it's absolutely true. We pick the top people in science and put them into medicine. We don't take the top people in arts and the top people in communication and the most passionate people who just want to be a doctor. We take the most competitive people out of undergraduate and we put them into medicine. And then we teach them a biomedical model. We don't teach them compassion or sympathy. We don't even know if they have compassion. We don't focus on the psychosocial aspects of everything that we do. And we basically teach them to be little internists and then send them off to the world where then we overwork them, burn them out, and wonder why they have no compassion for somebody who questions anything they say in their narcissistic authority. And we wonder why the system is broken. Well, there's the reason, part of the reason the system is broken. When it comes to education, I can say in Canada, we've done some good stuff. The Association of Faculties of Medicine of Canada has developed a national curriculum. And I probably, Launette, you were part of that. I was one of the reviewers. That'll be coming out to all the medical schools where we'll have a similar platform in teaching addiction and pain. And so hopefully that's going to improve. But as we mentioned before, veterinarians have better training in pain than we do. So, we really, and then you look at the coverage. So, most insurance providers, no matter if you're in the US or here, will cover meds, but they're not going to cover the psychologist or the therapist or the kinesiologist or the interventionalist. None of that's going to be covered. That's a problem. Then you look at the system of how docs are paid. They get paid to see more people. They don't get paid to spend time with people. So there's another problem. We could go on and on of the systemic problems, but it really lays back to we have a burnt out medical system and patients looking for help who are also burnt out, running into each other in a hospital. It's a recipe for disaster. And that's where we've got to fix everything is start from the very beginning, break it down and rebuild it. And that ain't going to be easy, but that doesn't mean it shouldn't happen.
There is passion in this conversation, and I know it might seem very basic, but I think it's exceptionally important. We're going to get into a little bit of a rapid fire. I'm going to ask some questions that some of our attendees have posed. I'd like to keep this going for at least 10 more minutes. Thank you, everyone who's still joining us. I see some nods. Excellent. So along the lines of the relationship, the therapeutic alliance, we've heard that. And actually, Rob, you mentioned that well. There's a question, for Launette. How do patients relate to discussions about hyperalgesia, and how can you safely have those conversations with having a negative impact on that relationship?
Oh, I think because also I do research in this area, and I found it so fascinating to discover, because this is the lived experience of patients who talk to me. And so I just share it from that perspective. I share that what we used to just think there was no ceiling effect and we could just keep prescribing as people got tolerant. And that was what we were taught, and that's what we did. But what we didn't know as physicians is that we might be causing some harm as we crank the doses up and up. And I'm sorry that we did that, but that's just the reality. And so now we have new information that high dose, very potent opioids may actually change your nervous system to actually give you more pain, which is the opposite of what we'd intended. So sometimes there's a better balance. There's a sweet spot where the dose can be a bit lower and people can get a bit less pain, but they can still get pain relief. And some people need to come off completely, and some people can't come down at all, or some even need a dose increase. Depends on your situation. But let's talk about what's right for you and what you've tried. And and then I do simple explanations of opiate-induced hyperalgesia. And also I talk about alcohol-induced hyperalgesia, and other drugs can make you hyperalgesic. And I talk about in animal models, just 5 days of drinking can make the rat more sensitive. So it's not just a human phenomenon. It's not just thinking about it or feeling like you got a hangover or something. These are physiologic changes. And I think it's empowering. Patients want to know information. They had no, like the fellow that I presented that case report, he had no idea that his drinking pattern, first of all, that his quick withdrawal of opiates, like his doc had done with good intent, but perhaps not such a great move for him, had induced a lot of pain that was unnecessary in him. And then by us, that there was some treatment for that. And also he didn't know that his drinking, because his lived experience was that it was helping, he didn't know that it was also harming. So he only found that out when he went through this process. So I think that these kind of things, and doing things little by little, in that case, it was an inpatient admission. I mean, we would have done something similar, and I've done for many patients over months as an outpatient. So these kind of things, when you have experience doing them over and over again, it becomes not a barrier at all to speak with people. And they're usually quite grateful that they have new information.
Well, thanks. And actually, that's a perfect segue, because we've got folks with lived experience here. And so when you think of the words like opioid-induced hyperalgesia, withdrawal pain when we go through a taper, or a slow, gradual reduction in an opioid dose, pardon me, it's getting late for me too. What were those conversations like with your health team, Guy and Claudine? Again, was that something you had done your research on, which I'm sure you did, or were those things where it was an open, fluid conversation? And what was that like?
Yeah, so as an individual living with pain, I know what withdrawals feel like. I don't know the clinical term of hyperalgesia. I don't even know how to say it. So, but I know what you're talking about. And it's, again, it's those layman words, and being able to meet us where we're at, and being able to talk to us like we're human beings, and we can make informed consent from there. And I'm so grateful for these conferences, because I can now learn your language and you can learn mine. And it's an opportunity for us to meet in the middle. But yeah, withdrawal, definitely, I know what that is. And I say, I feel shaky. I feel nauseous.
Yeah.
I'm struggling to have any kind of ability to eat. I'm not sleeping. My clinician, my practitioner can infer to a clinical term that they understand what that means, right? And so it is a little bit of, I'm going to use this word and you're going to use that word, but we're going to meet in the middle and find some common ground.
Yeah, with myself, obviously, I know my withdrawal. I know what it feels like. I've been through it many, many times. Used to get incarcerated. They give you Gatorade. There's no, you're going to suffer. And I'd gone through this suffering for decades where I'd be arrested and, I can't sleep for 60 days. I'm in withdrawal for 30 days. I mean, astronomical. And when I'd gotten out, and I was on a methadone and I switched to Suboxone in my early 9 months of recovery, I'd gotten to the point where, obviously why I'm so passionate about trauma therapy is it really helped me. Counseling and trauma therapy helped me understand my relationship with substances. I walked into my doctor's office. I had boxes of Suboxone, and I just said to her, I'm coming off. And she looked at me, oh, okay. And I said, I'm just going to do it myself. And she said to me, Guy, if you ever need a script, please call me and I'll fax one immediately. And I said, no, I'm doing this. And I've never looked back. And it's interesting. I'll tell you something that just happened about 3 weeks ago, because I really started to understand my relationship with my substances. I had surgery. I got out of surgery and I was in extreme pain. I said, I need something. And they said, we have pain meds. They gave me fentanyl, the drug that I was actively seeking in my addiction. And when they gave it to me, I still felt the pain. He says, I just gave you the minimum dose. I said, well, maybe give me a tiny bit more because it's not going away. And he did. And then it went away. And I remember, and then he said, we have much more of it here for you throughout the day. If you need it, just call us. And I was laying in the recovery bed and I was saying to myself, well, I don't need any more. It's done what I needed it to do, which was alleviate the physical pain, but the emotional pain that had kept me trapped for so long had been dealt with. And I no longer needed this substance to do what it needed to do. And so that was really the one of the most powerful things, is that not understanding my relationship with the drug that I have or why I use it or what triggers me to use it was the benefit of why, like, I don't need substances today. And so that's the credit to the work of many people. And I was just lucky that I got a counselor. And unfortunately, the people that need trauma therapy the most are the ones that can't afford it. And that to me is unacceptable.
Thank you for sharing that really recent discovery. And I think we need to honor that. And so thank you so much. I'm going to build on that conversation that we have right at the beginning with opioids, with folks living with pain. And I'm wondering if we can look at, let's say the conversation is to reduce. It is maybe to consider a reduction. And so there's a question posed, and I'll leave this open to whoever would like to answer this. The question is the rate in which you were to taper a patient's opioid dose related to or affected by the length of time they've been on the drug at a higher dose?
Often, yes. It's influenced by a whole bunch of different things, but it can be influenced by how high the dose is, how long they've been on it. Also, things like hyperalgesia can be influenced if you're in and out of withdrawal, for example, with heroin on and off. So there's many factors. Your mood is a factor. Past trauma is a factor. Other psychiatric issues, the catastrophizing. There's all sorts of different things, and how safe you feel to undertake this and how ready you are for the change. There's many, many factors. And of course, it helps to have this, we have been talking about, like Stefan said, these are ideal settings where there's multidisciplinary teams involved. A lot of the data that he presented were people in the real world who did not have a multidisciplinary team, whose doctor just got, used to be prescribing because pain was the fifth vital sign, and they got paid by performance review. So if you didn't give the patient an opioid, you'd get dinged. So people gave a lot of opiates. Then it got shifted to a situation where they got dinged if they did have their patient on an opioid. So the doctors are suddenly reducing patients against their wills into very low levels. And like that poor man in the VA who had all the kids that you showed the photo of, that him committing suicide because he didn't have proper pain relief. Like, that's just unconscionable. But not many people have access to the full interdisciplinary care that Claudine was talking about, that helped her make all the changes she needed in order to do this. So we have to do what Rob is talking about, which is to be able to help teach family physicians to do more of this in more stepwise ways. So I teach, and many other docs I know who do this work, like Rob, we're teaching. And that's what conferences like this in part are for, trying to teach more and more people about all the subtleties of this so that we have a broader language and are more nimble to be able to address these very complicated issues.
Yeah, no, thank you. Unfortunately, Guy had to leave, so he gives his regrets, and I'm sure you might have seen him say hi, bye. So I think, the conversation, again, a perfect segue into the multidiscipline approach. Who needs to come alongside when these conversations are being spoken about, when it's informed, when it's consensual, when it's, I'm open to this, however, I'm nervous about this, or I don't even know what this is going to mean. So who needs to come alongside in that healthcare team, whether it be through other resources at another program, or I have the pleasure of being a part of a primary care network where we have allied healthcare teams. So who needs to be a part of that team? And I can start with you, Claudine.
Well, for me, it was my GP definitely felt that she needed more information, and she needed more support. And from having the opportunity with the opioid deprescribing clinic, that comes with a team. That comes with nurses. It comes with a prescribing physician. It comes with a therapist. And as I mentioned, not only are they working with me, they're working with my family and my support team. So we are the only ones of our family that live in Alberta, and everybody else is in Ontario. And so for my husband to be able to understand what I'm going through, he's lived through 20 years of this with me. He gets it from my side. He doesn't understand the how to support me as I'm going through this change. And you heard me talk about having to have the biopsychosocial happening in parallel. I could not have gone through this program without that. I know how expensive that can be. And yet it was free for me. And I'm so grateful for that. It's unheard of. And you heard, Dr. Tanguay talk about the opportunity for us to be able to expand and do more of that. But this is a teamed approach. You heard about me talk about my pharmacist. He can make sure that I'm getting what I'm supposed to be getting. He knows my records. He's been with me for a while. He can intervene and connect with me. I think, I have an ART therapist that helped with PSTD, and she's fully informed. My records go with me, right? That's the other thing. My records go with me to whoever I see for whatever therapy I see, and they're part of me. I'm a whole person because of those records. And, I'm a big believer in you never lie to your medical team. It does absolutely no benefit. That takes a lot of courage. That takes a lot of strength, but it's something we need to do. And I think that's best practice. So that's my 2 cents.
I just want to add something. For people who are in rural communities or in an area that don't have these multidisciplinary teams, don't have access, or the wait list is months or years long, I have heard primary care physicians tell me some of their tricks. So for example, utilizing pharmacists like Claudine is talking about. Those pharmacists can help us as physicians write up titration schedules of all different medications, or tapering, you don't like the word tapering, deprescribing schedules. We can also do things like group visits and bill for group visits, stay in the room, do our paperwork, but have a physiotherapist come and lead the group visit, or a psychologist lead the group visit, or an occupational therapist lead the group visit. And you share half your money with the practitioner who's come in. It doesn't cost you anything. Half the money, you have to pay taxes, so you have to take half of it. You give them half of it. And everybody wins, and your patients are so happy because you can build a multidisciplinary team this way. So it's not perhaps ideal in the same way, but there are a lot of things you can do. You can help your patients get passes to gyms and things like that are under disability, so that they have discounts. I mean, there's lots and lots of resources. As well as the formalized programs. And there's lots of stuff online, and you can use workbooks and tear off sections and give assignments to the patient, to do a certain thing online, so you don't have to teach it, and come back and discuss it on your next visit. So there's ways to be clever with this. We just need to expand it. I think with depression care, a lot of primary care physicians have learned those kind of tools, but we haven't applied it to pain yet. And I think that's the next wave.
Yeah, just general education, maybe. So, there's one last question here that I think is really important. And, there are differences across the border. Even if it's closed right now, there's still differences. And some of the differences, and we heard this from, the heads of the USASP yesterday or on Friday, primary care is in disarray, these X waivers, you can't even get access to what we don't even need a triplicate or special prescribing rights or education or anything. Suboxone's almost like naloxone, and it should be. So, Stefan, if we could step back and look at pain and opioids, what can we do? I mean, if we could take a practical approach on a primary care level, what can we do to support our primary care physicians and our patients who are on opioids right now?
So a few things come to mind. First of all, doing a comprehensive assessment of a complex array of issues, from post-traumatic stress to a history of medication receipt, and then navigating a very sensitive conversation is a big task. And most people who do primary care are being paid and compensated for many small tasks. And they're generally not encouraged to create a visit and to bill a visit and to be reimbursed for a visit that's actually going to be a longer one that might involve multiple professionals working together. Within the United States Medicare system, there are some possible ways to bill for such work, but they're not highly distributed. So one element is to encourage primary care teams to both take advantage of the mechanisms to bill for service that are there, but also you need to probably compensate and incentivize them to sort of move toward that. There's the other thing that has to be acknowledged is that in the US context, there's such a heavy emphasis of our criminal justice enforcement in the realm of the healthcare where opioids are involved. And the sense that the same quality metric that we talk about as being just a guideline, but is also sort of tied to criminal justice referral, that really creates a very fearful environment for the clinician, which, I mean, we've just been talking about how the people who are in pain, who are seeking care, need to be respected as authentic, and their experience needs to be valued, respected, and heard. A clinician who's very afraid often has trouble hearing. So I would love to see a longer term agenda in which the intensity of that criminal justice focus is reduced in the US context. I do think that there's a way in which non-physician clinicians like nurses and pharmacists, by the way, even though I had an anecdote of a pharmacist where things didn't go right, they're actually often really well positioned to be superb counselors and superb people to engage with others. And we actually have to create space in the clinical day for them to learn those skills and to deliver them. And all of it has to be in the context of recognizing that where the science is not going to strongly support a single standardized way of doing it every time. There has to be room to sort of permit the flexibility that is achieved through negotiation. And I think systems can create that, but they have to ramp down on the fear factor in order to allow that to happen and create some billing opportunity.
I do got to say, we don't have, thank goodness, like the DEA or anything like that here in Canada. We are self-regulated with our colleges. And certainly our colleges can change province to province. BC and Ontario were pretty aggressive on their physicians compared to the rest of the country. But at the end of the day, I think what you said is absolutely right. We got to take the fear away from the physicians and put the people who have all the expertise in this area back in charge of supporting their patients. And then allow that relationship to go where it's going to go. Allow negotiation to occur. It was Tracy Fossum who had that amazing thing. I realized it was me and the doctor and the guideline and the college and it's no longer the patient and the doctor sitting together in a room. It's everything else clouded all around it. And your cartoon was brilliant, Stefan. I mean, you know, I think it really exemplifies how a lot of patients are feeling, but at the same time, you know, as someone who and Launette's the same, we work in both worlds. We cross back and forth all the time. The one thing that I make all my residents and trainees do is read all the trauma screening, and they're always fascinated that it almost looks exactly the same no matter which side they're on, whether it's addiction or whether it's pain. The underlying trauma is huge. But I really appreciate that. And we got to put the power back in the physician so that the physician can work with the patient. And I'm using, you know, very kind of stigmatizing words of patient and physician and power, but it's all about that relationship so that they can work together and not have all of those other clouded factors around them. And then allow science and evidence to get there. Science says for some people, opioids make a huge difference in their life. Science says for some people, opioids, getting off of them makes a huge difference in their life. And so we've got to be able to individualize and think and not be so overwhelmed by everything around us that we can't think. And as brilliantly said, we can't listen. So I'll pass it over to Christelle, but I mean this from the bottom of my heart. Thank you for taking the time out on Sunday to join us. I really hope, I think we are last check, we are still well over 700 people live with us. So thank you everybody who's watching. More importantly, I hope we've changed somebody's life on Monday, and maybe some policy person is watching, because maybe we should have doctors doing some policy for once as well. Because if you actually put the person with 15 years of university in a position where they can actually support a system, maybe we could get somewhere. But maybe these policy people are watching, and we can make a difference for the people that matter. And those are the people with lived experience and people living with pain and people living with complex chronic disease. I'll pass it over to Christelle.